Hello, everyone, and thank you for joining us for the second class in our Spotlight Learning series on the Learning Health System, Ensuring Public Trust. This is Kate Berry, CEO of National eHealth Collaborative, or NEHIC. NEHIC is a public-private partnership working to advance nationwide health information exchange, including educating stakeholders on related topics. For today's class, we are pleased to be joined by Dr. Charles Friedman and Joy Pritz from ONC and Laura Adams of the Rhode Island Quality Institute. I will introduce them very, very shortly. We're looking forward to hearing from our speakers and to having an interactive Q&A session with the audience. Next slide, please. NEHIC has recently expanded our education program and rebranded it as NEHIC University. Our new class offerings provide a broad and deep view into the rapidly changing health IT landscape. Next slide. Before turning it over to our speakers, I'm just going to provide a quick overview of NEHIC University. As part of our expansion, we created the NEHIC University Advisory Council. As you can see from the names on this slide, the council has representation from virtually every segment of healthcare: physicians, hospitals, payers, government, academia, and more. The Advisory Council will play an important role for us. They're going to help us shape the curriculum, serve as faculty, help recruit additional faculty, and provide additional advice to us. We're very delighted to have them as a part of our extended NEHIC team. Next slide. Here's an overview of our programs. We're offering industry leader briefings, health IT orientation, health IT policy and standards committees quarterly updates, guest lectures, health IT trends, Spotlight Learning series, and a continuation of our NIN University 300 series. Many of these classes can be viewed on our website at nationalehealth.org. Next slide. This quarter, we're offering two Spotlight Learning series. You're attending the second of the three-class series on the Learning Health System. The first was an introduction led by Chuck Friedman of ONC and Claudia Grossman of the Institute of Medicine. And the third and final class of this series will be held next week on June 23rd and will cover the technical infrastructure required to build a successful learning health system. The speakers will be Rich Platt and Jeff Brown from Harvard Pilgrim Healthcare. Our other Spotlight Learning series this quarter is on accountable care. This three-class series began on June 2nd with an introduction to the proposed rule and an example of a payer-provider risk-sharing model. On June 16th, we'll have our next Accountable Care Spotlight Learning series. We'll have Jordan Batani from CSC, Caroline Steinberg from AHA, Keith Moore of McManus Consulting, who did the ACO cost study for the American Hospital Association, and Victoria Viglucci, the former CIO for the Greater Rochester Independent Provider Association and now CIO for Accountable Care Solutions. The discussion will focus on the core competencies for creating a successful ACO, key challenges, and potential solutions to those challenges from multiple different perspectives. The third and final class of this series will be moderated by John Glasser, who will also share his views on accountable care. And we will have Dan Garrett from PricewaterhouseCoopers, Renee Carter, a practicing physician and Chief Medical Officer with Accountable Care Solutions. This discussion will focus on examples of emerging models for ACO development, critical success factors, and potential future models, with an emphasis on HIT integration and how ACOs map to the stages of meaningful use. Next slide. Just some housekeeping items. The slides for this webinar are available at the URL on your screen. The recording will be up in a couple of days, and a transcript will be available in about a week or so. So you're also going to find some supplemental materials on our website. During the webinar today, please feel free to ask your questions at any time by entering them into the Q&A box on the right of your screen. And you can also email us, tweet a question, or comment on our Facebook page, as you see on the screen. Now I would like to introduce our speakers. Dr. Chuck Friedman is the Chief Scientific Officer for ONC, As ONC's chief scientist, he leads a group responsible for tracking and promoting innovation in health IT, research programs to improve technology, applications of health IT to support basic and clinical research, evaluation of all of ONC's programs, programs to develop the health IT workforce, and for activities supporting global e-health. Dr. Friedman served as Deputy National Coordinator for 2 years prior to his current position. We'll also be joined by Joy Pritz, who joined ONC in February of 2010 as the very first Chief Privacy Officer. Joy advises the Secretary of HHS and the National Coordinator in developing and implementing ONC's privacy and security programs. Prior to joining ONC, Joy held a joint appointment as Senior Scholar with the O'Neill Institute for National and Global Health Law and as a Research Associate Professor with the Health Policy Institute at Georgetown University. And Laura Adams is President and CEO of the Rhode Island Quality Institute, a collaboration of the top leadership of healthcare stakeholders working together to transform the healthcare system in Rhode Island. The Quality Institute is the only organization in the country to be awarded all 3 of the major high-tech grants: the State HIE Program, the Regional Extension Center, and the Beacon Community. Laura served on the Office of the National Coordinator's Health IT Policy Committee's governance panel for the Nationwide Health Information Network. She is the immediate past chair of the board of NEHIC and continues to serve on our board. Laura also chaired the Institute of Medicine's Planning Committee for the Digital Infrastructure for Population Health and a Learning Healthcare System workshop series. So now I'd like to turn the virtual podium over to Dr. Charles Friedman for his introductory remarks.
Thank you very much, Kate, and I hope everybody can hear me. My remarks will be brief. I'm the setup band today for Joy Pritz and Laura Adams, and I'm delighted they are part of this session today, and I know you're going to appreciate their remarks. What I'm going to do is give a brief overview of many of the points that were made in the first class in this series. For those of you who were at the first one, I hope this will provide a bit of continuity between what happened a couple of weeks ago and what's going to happen today. And for those of you who weren't at the first one, it's all good. What I'm going to hopefully be able to do is give you enough of a basis of what happened and what was discussed in the previous session that you can pick right up on what our 2 featured speakers are going to present. So let me get into that right now, and I can advance these slides myself. So first of all, we are using as a definition of the learning health system a definition put forward by the Institute of Medicine, which you see on this slide. A learning health system is one where science, informatics, and care culture align to generate new knowledge as an ongoing natural byproduct of the care experience and seamlessly refine and deliver best practices for continuous improvement in health and health care. So that's a definition in words. Here's a definition in pictures. This shows diagrammatically what a learning health system for the U.S. might look like, and I'll point out some features of this diagram. First of all, the learning health system can be envisioned as some kind of federation of entities. We don't know exactly what kind of federation yet this will be, and actually this is one of the topics that Laura Adams will be addressing. These entities who participate in the learning health system will be able to both contribute data either really or virtually for purposes of analysis of various kinds, and also benefit from the knowledge that is created from those analyses. And you see this represented by the bidirectional arrows going to this cloud representation of what the learning health system can do and coming out from it. This shows the contribution role of the members as well as the knowledge reception role and benefit of the members. The activities that must be undertaken and functions that must be realized in order for a learning health system to function are the ones that are represented in this cloud. And let me say that the cloud is sort of figurative here. We're not sure we literally mean cloud computing as it currently is understood, but a cloud is a nice way to embody figuratively here the many functions that a learning health system will need to carry out. And those functions include governance, patient engagement, the all-important maintenance of trust on the part of the public, capabilities for conducting analysis, and as I said, capabilities for disseminating back to the members the results of these analyses. The main points from the first session include the key fact that the National Health IT Agenda targets a learning health system as one of its key objectives. Another important point is that as important as meaningful use is to the National Health IT Agenda, meaningful use of certified electronic health records represents a necessary but not sufficient condition to build a learning health system, and this gave rise to a very compact, formulaic way of viewing the challenge that lays before us, which is to build that delta, which when added to meaningful use will give us the learning health system. And then in the first session, several comments were made about where we are in advancing toward meaningful use. To illustrate how the learning health system is a pillar of the Federal Health IT Strategic Plan, we've represented here the 5 key goals in the strategic plan, which has been out for public comment. We received many comments back in the process of revising that plan now for final clearance and release. And you will see Goal 5 of this strategic plan specifically articulates the achievement of rapid learning and technological advancement through the creation of a learning health system. You will also see in the other goals, although I won't have time to elaborate on this now, elements of a learning healthcare system embodied in the other 4 goals of the plan. Meaningful use is necessary but not sufficient for a learning health system. As I said before, there are many ways to see this. One key point to emphasize here is that meaningful use is defined legally as a status that is achieved individually by eligible professionals and hospitals to qualify for the CMS incentive program. Even though there is much that is important, that is built into what a meaningful user must achieve in order to attain that status, a learning health system, by contrast, is a system that includes these professionals and hospitals and binds them together through systemness, the public trust and support that will be attained through patient engagement, through the ability to virtually or actually aggregate data, which can be seen as a very, very sophisticated form of health information exchange, and how this data aggregation will occur will actually be a major theme of next week's class. A learning health system also requires the ability to conduct analyses that convert data into knowledge, and again, as I said, the ability to disseminate that new knowledge back to the members of the learning health system to engender behavior change, which in turn will improve the quality, efficiency, and safety of health care. We have a grand strategy that we are evolving which really has three parts and can be seen as derivative from that simple formula I've presented. In this grand strategy, we are going to simultaneously build toward national meaningful use. We are going to build this delta, these other elements, which on top of meaningful use will get us to the learning health system. And perhaps most important, we will do each of these as we do them simultaneously in a way that anticipates the other, so that in the end we will have the pieces that mesh into a smoothly functioning system. I was remiss in not including a slide about this, but this grand strategy is being informed by a report that was a feature of the first class and presented by Claudia Grossman of the Institute of Medicine. This is the report entitled The Digital Infrastructure for a Learning Health System. It can be obtained from the Institute of Medicine website, and I would encourage you, if you have not looked at it already, to get a copy of this report and read it to greatly deepen your understanding of what a learning health system is and many of the activities that must be undertaken and achievements that must be realized in order to build that delta on top of meaningful use, which will get us to the fully functional learning health system that I depicted in that earlier diagram. I'm going to skip now to slide 16 and just conclude my brief remarks by pointing to three of the functions of the learning health system that are depicted in the cloud: governance, patient engagement, and trust, and make the framing point that our two speakers in this session, our two featured speakers, will be engaging these aspects of the learning health system function, whereas the dimmed out aspects of analysis and dissemination in this particular figure and how technically those can be achieved will be the focus of next week's session. So that concludes my brief remarks. If you have any questions for me specifically, feel free to write to me at this email address, and of course at healthit.gov you can always attain greater amounts of information beyond what was presented here about all of the programs coordinated through ONC. Thank you very much.
Okay, are you ready for me to jump in?
Yes, sorry, Joy. Yes, please, you're up next. And once again, Joy Fritz, the ONC Chief Privacy Officer.
Good afternoon. I'm going to speak to you today about privacy issues in the learning health system. I want to start off by saying initially I was going to talk about privacy and security issues in a learning health system. However, there is so much material to discuss just about privacy that we are going to limit the discussion to that topic today and put off security to another day, although it is equally important. Next slide, please. I'm going to cover today just a general overview of HIPAA, the Health Insurance Portability and Accountability Act, which is the source of many of our privacy protections in the United States. And then I'm going to move into a very specific discussion of HIPAA as it applies to public health, research, and quality improvement, three of the anticipated key functions of a learning health system. I could easily spend hours talking about each of these topics, but given our limited time, I will resist doing that. Instead, I'm going to focus on some pieces of these laws that are particularly relevant to a learning health system. I know a lot of you on the phone are probably very familiar with HIPAA, and some are less familiar. And you may be thinking, well, why is she skipping certain topics? But there is a method to my madness, and that is just to focus on the things that I think are really going to be the most important aspects from the learning health system to keep in mind as we go forward. Next slide, please. Okay, so HIPAA comes from the Health Insurance Portability and Accountability Act of 1996. It was recently modified in 2009 by the Health Information Technology for Economic and Clinical Health Act of 2009, also known as HITECH. Together, these two acts establish the scope of who must comply with HIPAA, and they create the framework for the interaction of the HIPAA privacy and security rules with state law, commonly known as the preemption framework. Next slide, please. The implications for a learning health system are that to the extent that as we move forward, it is as a policy determined that potential changes need to be made. Only Congress can change certain things about this paradigm. Only Congress can change who is directly covered by HIPAA or who is subject to its requirements. Only Congress can change the preemption framework. The penalties, civil and criminal, are also established in statute. And some of the privacy standards, primarily which are contained in HITECH, are also only modifiable by Congress. However, most of the privacy standards for protecting health information are contained in the privacy rule and can be changed by HHS. Next slide, please. Who is covered by the privacy rule? What information is protected, and what standards does the privacy rule set are going to be our next set of topics. Next slide, please. HIPAA directly regulates covered entities, which include health plans, healthcare clearinghouses, and healthcare providers who transmit health claims transactions related information electronically. These are kind of general, there are nuances to each one of these subcategories, but for our purposes, this kind of overview is sufficient. It also directly regulates the business associates of covered entities. Business associates are entities that perform certain functions on behalf of a covered entity using protected health information. HITECH specifies that business associates include health information exchange organizations. One of the pieces of this provision that's really important to recognize is that whether an entity is a business associate or not is not determined by whether they sign a contract. It is determined by whether they perform the functions on behalf of a covered entity. Next slide, please. So what are the implications for a learning health system? Not everyone who will participate in who may participate in a learning health system will necessarily be directly subject to HIPAA. For example, there may be healthcare providers who share clinical health information electronically, but who do not engage in electronic HIPAA-covered transactions. An example of this might be a boutique healthcare provider who only accepts cash payments and does not accept health insurance. Some of the healthcare providers that practice on the Internet only accept credit card payments. In both of these situations, they would not necessarily engage in insurance-type transactions and wouldn't be covered by HIPAA. In addition, there are others who might use and share health information without even being a business associate. One of the keys to look at there is whether they're performing the function on behalf of a covered entity. In particular, researchers often can fall outside of direct HIPAA regulation. The ones that provide health care directly to patients are often subject to HIPAA privacy rules, but there are quite a few researchers who fall outside of HIPAA because they are researchers and they are not health care providers. Some of the greater implications for this are that the fact that not everybody is on the same playing field can create some trust issues. And there have been some instances where people who are covered entities or organizations who are covered entities have been very hesitant to share health information with a third party that falls outside of HIPAA and also falls outside of a business associate agreement. Just an interesting piece to keep in mind as you move forward. Next slide, please. What information is covered? Most of you, I'm sure, have heard of protected health information. It's information about a person's past, present, or future health or condition, their health care or payment for health care, which identifies or with respect to which there is a reasonable basis to believe can be used to identify the person. And it was created or received by a covered entity. A learning health system would probably use both kinds of information, that which is protected health information, which there is a reasonable basis to believe can be used to identify, and also additional types of information. Next slide, please. Protected health information includes health information on decedents up to 50 years after their death. This year limitation was proposed by some of the high-tech regulations. And it excludes de-identified information. It also excludes cells and biological tissues, but it includes the analysis, communications, or other identifying information related to such physical items. So it would include the information about the tissue, but not the tissue sample itself. Next slide, please. What are the standards set by the privacy rule? There are a lot of different provisions in the privacy rule. They can be grouped into some overarching concepts. The first is that it creates rights for individuals with respect to their own individual identifiable health information. Included are the access rights, the right to see, copy, and amend their information, and the right to an accounting of disclosures. And there are others which are probably not as important for purposes of a learning health system. It also creates use and disclosure limitations, and those terms are defined very specifically in HIPAA to mean reviewing information and communicating within an organization, as opposed to disclosure, which is sharing information beyond or outside of the organization. The privacy rule also requires that covered entities and the business associates safeguard information, which we call the mini security rule, and it has administrative requirements. Next slide, please. I'm going to focus now for a while on the use and disclosure rules because I think these are going to be some of the most important rules for a learning health system. A covered entity may only use and disclose protected health information with the individual permission, their authorization, it's a written permission generally, or pursuant to a provision of the privacy rule that otherwise expressly permits the use or disclosure. There are a number of provisions in the privacy rule that do otherwise expressly permit use or disclosure, and we're going to review some of those now. Next slide, please. Probably the largest category for this exclusion is the ability to use and disclose health information for treatment, payment, and healthcare operations without the individual's express permission. Healthcare operations include quality assessment and improvement activities. There are also a number of public interest purposes for which information can be used and disclosed without the individual's express permission, but each of these is subject to detailed conditions. They include public health, research. I'm including law enforcement here just so to give you a range of how the different types of how broad the different types of public interest purposes can be, as well as other specified uses and disclosures. Next slide, please. How does all of this interact with state law? HIPAA is based on what we call a conflict preemption model. HIPAA and HITECH override provisions of state laws, which include statutes, regulations, and case law, relating to the privacy of health information that are contrary to HIPAA. And what this means is that state laws that protect privacy in a way that is equal to or similar to or greater than HIPAA, they remain effective. To the extent a state law is less protective than HIPAA, then it is preempted and it falls by the wayside. Next slide, please. You know what, can we go back one slide just for a moment? What I'd like to point out here is that in HITECH, Congress specifically addressed whether this preemption framework, which was first set out in HIPAA in 1996, should remain in place. And Congress specifically decided that this framework with state laws that afford higher protection remain in place would still remain the preemption framework in the United States in this area. Next slide, please. How does HIPAA interact with other federal laws? Because HIPAA is not the only federal law that addresses health information. There are a number of other ones. And with respect to other federal laws, the federal laws that are at least as protective as HIPAA remain in effect. There is an analysis that is done which is somewhat similar to a preemption analysis as to whether a law that was passed afterwards, after HIPAA, is intended to implicitly repeal parts of it. But as a general rule, covered entities must comply with multiple sets of federal laws, even if they are equally protective. Next slide, please. HIPAA is enforced by the Office for Civil Rights of Department of Health and Human Services. It is complaint-driven primarily. There are also audits that are authorized, and there is an audit program which is mandated by the HITECH Act. And there are also civil and criminal penalties which are set out in HITECH and which can be imposed by the Office for Civil Rights. Criminal penalties, of course, move to the Department of Justice for consideration, proposed criminal penalties. And they are the department which actually processes and prosecutes criminal cases. Next slide, please. So now we're going to turn to some of the specific uses, purposes for which health information would probably be used in a learning health system. And one of those which has been proposed is the use of health information for public health purposes. This is one of the areas that is really very clearly addressed in the Act of HIPAA, the statute. And it provides expressly that the privacy rules and other conditions of HIPAA do not preempt state laws that provide for the reporting of disease or injury, childbirth, child abuse, birth or death, public health surveillance, or public health investigation or intervention. Next slide, please. This statutory provision is interpreted in the HIPAA privacy rule. It's given they put some more meat on the bones, as is often the case in rulemaking procedures. And under the provisions for public health in HIPAA, a covered entity may disclose to a public health authority that is authorized by law to collect or receive protected health information for the purpose of preventing or controlling disease, injury, or disability, including but not limited to reporting of disease, injury, vital events such as birth and death, and the conduct of public health surveillance, public health investigations, public health interventions. Next slide, please. In addition, a covered entity may disclose PHI to persons subject to FDA regulation with respect to their FDA-regulated activity or product for which they have responsibility. And the purposes for that disclosure are limited to activities related to the quality, safety, or effectiveness of the product or activity, including collecting and reporting adverse events, product defects or problems, tracking FDA-regulated products, enabling product recalls, repairs, replacement, or look-back, and conducting post-market surveillance. Next slide, please. Under the public health provisions, a covered entity may also disclose protected health information to persons who may have been exposed to communicable disease if that the public health authority is authorized by law to notify such persons as necessary in conduct of a public health intervention or investigation. They may also disclose to employers about workforce members for workforce-related medical surveillance in limited circumstances. So you can see from these selected provisions that there are a lot of public health activities for which a covered entity may disclose protected health information without the patient's express permission. Having said that, you'll also notice that the provisions don't allow disclosure to just anyone. They are limited to public health authorities, for example, and they are limited to those that are authorized by law to conduct certain activities. So there are a number of conditions that are present here before the information, and that must be met before the information can be released. Next slide, please. Moving to the next topic, research is also one of the functions that is envisioned for a learning health system. It's important to recognize here that HIPAA is only part of the picture when you're thinking of sharing health information for research. There are other regulations that specifically address information and how it may be used in research or for research purposes. So the privacy rule does not replace what we generically call the common rule, which is the set of federal policies for the protection of human subjects. These rules, which are adopted by, I think it's 15 or so federal agencies, are very similar to each other. That's why they're called the common rule. They're based on the same set of principles, and they govern federally funded research. So they encompass a lot of research, but not all research that's conducted. Privacy rule also does not replace FDA regulations on the protection of human subjects. Very similar to the common rule, but slightly different. And the requirements for the HIPAA privacy rule for research purposes vary from both of these sets of standards. Next slide, please. As you will remember, the researchers aren't regulated as, quote, researchers under HIPAA. If they're healthcare providers, they may be regulated directly. Instead, what HIPAA does is it places the limits on disclosure and use on the covered entity. So you need to have that focus as we go through this next section. Some of the key privacy rule use and disclosure provisions affecting research include what type of information is protected by the privacy rule. For example, de-identified health information is not protected. So if health information has all of the specified identifiers removed, there are 18 of them, by most people's count, that include the name, the date, except years, social security numbers, things of that nature. All of those have to be removed. Then you are within the safe harbor and the information is considered to be de-identified. There is also provision that allows for statistical determination that the chance of redisclosure is very small. And in both of those cases, the information is de-identified. And if that's the case, it's beyond the privacy rule, and none of what we're going to discuss really applies to it. Assuming the information does not come within the de-identified category, then it may be used or disclosed with the individual's written permission, called an authorization. It's interesting to note that the authorization requirements under the common rule differ from HIPAA. For example, the ability to permit future research. Next slide, please. A covered entity can disclose and use protected health information for research without authorization if it is a limited data set from which most obvious identifiers have been removed. Some of them are allowed, some key identifiers are allowed to remain because these were thought to enable people to at least place people in the community and perhaps also track the individual over time, such as dates, zip codes, and coded information are permitted. And the limited data set, the use of a limited data set for research, which does not require written permission, does, however, require the use of a data use agreement. Next slide, please. There are a number of circumstances under which protected health information may be used or disclosed for research without authorization, even if it's not a limited data set. These include a waiver of the authorization requirement. The authorization, the waiver provisions here are similar to, but slightly different than, those under the common rule, which allow an institutional review board to waive the requirement to obtain consent to participate in research. It's a very complicated provision, actually, that is, I won't go into the details here. But it has worked for many. People are using this waiver provision to conduct research now, so people have been able to work through this. In addition, protected health information may be used for research that for conducting activities that are preparatory to research, which may be part of, I can see that becoming a part of the learning health system function. And it also permits the research on decedent information without their permission. Next slide, please. There are some efforts underway to try to simplify and better harmonize the common rule and HIPAA privacy rule. There was an IOM panel on this issue in the last several years, and have also been other advisory committees to HHS that have recommended efforts along this way. And most recently, there has been an NPRM notice of proposed rulemaking on the accounting and disclosures provision, which would effectively remove research from the type of disclosures that the covered entity would have to account for. Next slide, please. The learning health system is also contemplated for conducting quality improvement activities. Healthcare operations, that term for which covered entities are allowed to use and disclose information without patient permission, is defined as including, among many other things, conducting quality assessment and improvement activities, including outcomes evaluation and development of clinical guidelines. There is a fuzzy line here between quality improvement and research. The line is generally drawn as to whether or not the conduct is intended to produce generalizable knowledge. And some see that line as being drawn as to whether you're going to be publishing this research and publishing this activity and making it available to everybody and hoping that everybody adopts it as a practice, potentially. Healthcare operations also involve population-based activities related to improving health or reducing healthcare costs, and contacting healthcare providers and patients with information about treatment alternatives. All of these functions you can see taking place in a learning health system. Next slide, please. So the rules for using health information or disclosing health information for quality improvement are somewhat similar to the others that we just discussed in that there are conditions imposed. So a covered entity may use or disclose protected health information for its own quality improvement purposes, but it may disclose protected health information to another covered entity for its quality improvement activities only if each has or has had a relationship with the individual who's the subject of the protected health information being requested, and the protected health information pertains to such a relationship. So it's not just a general blanket provision saying that this information can be shared with anybody for any quality improvement purposes. As you can see, there are very specific conditions imposed. Next slide, please. So overall, what are the implications of the privacy rule for the learning health system? I would say it's like the movie. It's complicated. Health delivery and these rules are complicated. And generally speaking, I think the overall lesson that you can take away from this is that the rules for using and disclosing protected health information will vary depending on who's holding the information, what type of information is being disclosed, the purpose for which the information is being disclosed, and to whom the information is being disclosed. Next slide, please. Thank you.
Joy, thank you so much. That was quite an understatement. It's complicated. And that was really, you covered a lot. Thank you. So next we have Laura Adams, President and CEO of the Rhode Island Quality Institute, and she's going to touch on the organizing and governing a learning health system. And then after that, we'll open it up for Q&A. So just a reminder, at any point, and we have some questions coming in, but please do enter your questions as you think of them. So, Laura?
Thank you so much, Kate. It's a pleasure to be on with Chuck and with Joy, and I think a topic of just intensely interesting, but certainly complicated. In providing this information today about organizing and governing a learning health system, I want to give you the context for my remarks. As Chuck mentioned, I had the great opportunity to be the planning committee chair for the Institute of Medicine Digital Infrastructure for the Learning Health System Workshop Series last year, spanning from about March through the end of the year, and it was just a terrific experience. I'm going to contain my remarks to governance relative to what we discussed associated with the digital infrastructure. I'm certain that the whole learning healthcare system is going to have more complicated governance issues, but the governance of the digital infrastructure is complicated enough, and we have to start somewhere. So I do want to thank ONC for sponsoring that work through the Institute of Medicine, through Chuck Friedman's leadership. I think people came away from that feeling inspired, feeling like we had a bit of a sense of the path forward for this digital infrastructure. Again, it is definitely complicated, but exciting to contemplate because of the possibilities. So next slide, please. We had a series of meetings workshops that occurred in July of 2010 where we really looked at all the opportunities, challenges, and priorities across this idea of a digital infrastructure, what's out there, what might we want to draw from. Chuck gave us the opportunity to look at this with a clean slate, no presumptions of what we might be bound by. This was the system after next. And there weren't any limitations on our thinking, except he challenged us to think about the system after next, but think about doing it now, implementing that system now. So we looked at, in September, we took all of that opportunities, challenges, priorities work, distilled it into a concept, or at least some themes around the system after next, and then in October of 2010, actually developed some strategy scenarios. Now, this work really had four major areas of focus. We looked at technical progress, knowledge generation and use. How does that get done? Patient and population engagement was one of the richest thematic discussions I have had in a long time, where we really put this paramount front and center. And then the notion of governance of this learning health system, this digital infrastructure. Next slide, please. So I just wanted to give you a chance to take a look at who the planning committee was. It was a terrific group of people that put this together, and just as I start to reference some of the outcomes of that work, I wanted to give credit where credit is due to this tremendous planning committee that had so much to do with the outcomes of this work. Chuck referenced the report that we formally released in May, and I'll have that link for you at the end of the slides today. Next slide, please. So in thinking about the learning health system characteristics, Claudia Grossman may have covered this with you, but there's some important implications here for governing that I wanted to just, first of all, frame it so that you know what context we're referencing here as we talk about this digital infrastructure and how to govern it. You see here that we're talking about a series of characteristics that talk about things being very participatory, patient-anchored, the idea that patients are fully and actively engaged. There's a lot of implications here around the notion of consent. Consent was looked on very, very favorably in this group, and not as a constraint to what it was that we wanted to do, conversely, an enabler. So it was really looked at as something that would open vistas for us, develop far more public trust than we might have otherwise. Decisions are informed, facilitated, and shared. So there's a concept of shared decision-making here. The notion of knowledge being a seamless product of services and research. It's a byproduct. It comes out of the care that we're delivering every day, the research that we're compiling on this, the information that's being shared. It emanates from that and is produced continuously. I thought it was an exciting concept. The health information as a reusable resource. We're certainly talking about health information coming out of the source and then being repurposed multiple times for multiple uses. Data utility where it's obviously stored and used for the common good, but there's also a trust fabric associated with this. Protected. And you'll begin to feel a sense of pull and tug there. The idea that are these really counter to each other? Are they paradoxical? They are. And in fact, we'll talk about the necessity of that paradox when I talk a little bit about our underlying theoretical assumptions for this digital infrastructure. But the last one there, that leadership needs to be multifocal, networked. So networked leadership. So right there you can begin to see the implications for governance are that it is not the notion of governance as sort of the all-controlling directive making all the rules and others will follow in order to participate in the system. This is networked leadership that's dynamic. Someone may lead at this time, another entity leads at another time. So this presented just tremendous challenges to our development of concepts around governance because it sort of shook up what we're used to with the notion of governance being sort of the group that's in control. Next slide, please. So in looking at the infrastructure, common themes and principles, we definitely wanted to build a shared learning environment out of all of these. And what we mean by that is to base decisions on input that come from all parties and definitely including patients and the population at large. And you'll notice that there's a careful consideration and evolution of the name of this work evolving from the learning healthcare system to the learning health system. I think we've really begun to embed and understand the idea that the healthcare system is actually responsible for a very small fraction of healthcare status, and that we have to begin to understand that and work in that context. We also wanted to engage that idea of learning from populations of patients in the ways that we can, thinking way beyond what happens in the doctor's office or into the hospital and into decisions that are made in everyday life. People are constantly providing self-care for themselves and for their family, and understanding that the vast majority of health care takes place in that context. Then leveraging existing programs and policies. Well, we have this terrific opportunity to think very freely. We weren't thinking about a rip and replace or completely trashing the existing. I think most of us realize that it's not possible to build a bridge without starting somewhere with something that already exists. You can't build a bridge in the sky. So we very much respected existing programs and policies and sought to be educated about those, to understand how they might become part and parcel of what we would do going forward with this. We wanted to be sure that we already accelerated where progress was going on, and we certainly wanted to prevent waste and duplication. Wanted to embed these services and research in a continuous learning loop. We talked about the fact that we wanted these processes to be easy to use and ensure that they don't burden users unnecessarily. So thinking about how governance becomes, again, an enabler and not something that adds burden onto this, so that it stops the emanation of possibilities and learning. Anchoring it in an ultra-large-scale systems approach. I want you to pay particular attention to this idea of ultra-large-scale systems. You'll hear so much more about this. For those of you that are familiar with it, you know exactly where we're going with this. The idea that we want to base this on a set of technical and social principles that really meet the current and future needs of a complex system. And I will go into a little bit of depth about complex adaptive systems so that it becomes clear why there's an imperative for a concept like ultra-large-scale systems. Quite different than the way that we were conceptualizing building sort of a network, certainly not a centralized database of any sort, and not really like most of the networks that many of us have built already. This one has many more similarities to the Internet and fewer similarities to systems where there may be a centralized database and centralized control. So we're going to come back to our ultra-large-scale systems in a moment, but I really wanted to call your attention to that. Next slide, please. We wanted, again, emphasizing decentralization and specifications parsimony. That is the hallmark of the Internet. Decentralization and specifications parsimony, meaning that we have very simple rules, not a lot of algorithms, not a lot of density around control for the system. Now, again, that sounds paradoxical to the idea that we're going to completely protect privacy and build a trust fabric, but we're going to find a way forward on that. keeping use barriers low and the complexity incremental so that we can have maximum participation. This also implies that we let individuals determine how they want to use the system. Now, again, I'll go back to the idea of the Internet. The Internet's just remarkable utility, but we all sort of get to decide on how we use it personally, how our organizations use it, how our communities use it. There's a tremendous amount of innovation around the edges here. It's not dictated. So we wanted to be sure that the barriers were low, complexity incremental, to foster that same opportunity for innovation and creativity. Wanted to foster a socio-technical perspective focused on the population. Again, this means to be cognizant of social and cultural aspects of this challenge, which we all know, those of you that have worked in this for more than 5 minutes know that the social components of this are far more complicated oftentimes than the technical implementation. Again, weaving the strong and secure trust fabric, that Joy just did a great job of outlining a legal and technical framework for that, and I really learned a lot from that presentation and was happy to get that, because nothing that we would be deciding here works outside of a legal and regulatory and in some cases policy framework. Then providing the continuous evaluation and improvement. We want to be able to build governance for this system so that it constantly examines itself. How well is this working? How well is it adhering to these sets of principles that we came up with and adhering to the type of a system that we all had envisioned? Is it to the good? Is it not? What do we need to do to readjust? Next slide, please. I want to go back just for a moment as we get into this governance and just highlight for you those words that have tremendous implications for governance: patient-anchored, fully active and engaged, shared decisions. The fact that we're going to have a protected and a strong trust fabric, but we want to use the data for the common good, and that leadership here is networked, dynamic, and multifocal. Next slide, please. So in thinking about that, let's look at that ultra-large-scale system idea and think about then where it began to draw our group in terms of governance. It was important for us to consider what exactly is being governed here. And the idea of an ultra-large-scale systems approach gave us a lot of insight into how governance has to be structured in order for something like that to thrive. We're talking ultra-large, and this is in terms of all the lines of code, the number of people using the system, amount of data, all the words you see there on the screen, number of connections, interdependencies. It's actually the mind can barely comprehend. I know mind can't comprehend the enormity of a large-scale system. So think about global. We thought absolutely globally about this learning healthcare system. So we would have nodes and connections and points and users all around the globe, untold numbers that we could never track and understand. It's decentralized, developed and used by a wide variety of stakeholders with conflicting needs. That's what ultra-large-scale systems look like. They've got people with sometimes needs that are categorically opposed, not just conflicting, but really, really categorically opposed, that the same system can be used by people under certain frameworks. There's a lot of standardization at the center, and rather not a lot of, but a parsimonious amount of standardization at the center, and then lots of creativity at the edges. These are always constructed from heterogeneous parts, and they continuously evolve. Because they continuously evolve, the system gets better, and the basis of its evolution is on constant failure and rapid learning. We learn, in fact, more from components of the system that fail than we do the components of the systems that succeed. So we'll learn here by very, very rapid testing and trialing, and this very much in ultra-large-scale systems, it's absolutely the survival of the fittest. If you put something on an ultra-large-scale system for users to experience and interact with, and it doesn't meet need and it doesn't provide value, it dies very quickly in an ultra-large-scale system framework. Now, people aren't just users of this system, but they're elements of it. Every time they use the system, they evolve it, they adapt it, it's ever-changing. So, that sort of presents a very significant governance challenge when you think about the idea of this digital infrastructure being composed of this ultra-large-scale system. And there's great information about this that you can reference, and I'd be happy to provide people with more information on this approach. But we came to this in the course of our IOM workshops quite I wouldn't say rapidly, but it was faster than almost any of us anticipated, and we had almost complete agreement around. And now this isn't a consensus document in the sense of formal consensus out of the IOM. This is just a workshop series, but there was a tremendous amount of agreement that this thing could only happen under something outside of the constraints of our current systems, and ultra-large-scale systems seem to be the path forward on this. Next slide, please. So looking at the learning health system as a complex adaptive system with its implications for governance are such that when we're working with the learning healthcare system, it is a complex adaptive system, not a machine that responds to command and control. So people that are participants in this are independent actors. So when we think about maybe we want an object to get from one corner of a room to another. In a system where things are more, participants are not independent actors, it would be like we have a ball in our hand, and we could certainly calculate the arc, the velocity, and we could certainly linearly figure out what it takes to launch that ball out of our hand and have it land into the corner across the room. Well, complex adaptive systems are much more like, instead of having a ball in our hand, we have a bird, and we want the bird to go fly across the room and land in the corner. Now, the idea that we're going to throw that bird hard enough, some suggest we can just knock it out and toss it over there, but let's assume the bird stays alive. We have to do something different in order to meet aims when we've got independent actors involved that can make any decisions they want. We have to do something more along the lines of building attractors in the corner, like piling up some really tasty bird seed in the corner and causing the bird to want to fly to the corner. The other thing about these is that there's a notion of paradox in this. In order to govern complex adaptive systems that occur all the time, for example, ecology, termite colonies, communities, these are all complex adaptive systems. You can set frameworks in which they evolve, but you can't ever decide when they're going to go, how they're going to go, which is why, for example, our strategic plans for our organization simply don't outlast practically the moment that they're come back from the printer. They're already old. I'll paraphrase a famous saying that all plans are useful, or all plans are wrong, some are useful. And that comes from being in a complex adaptive system where we can't simply write a good enough plan with a comprehensive enough set of tactics, execution strategies. There just aren't enough of those, and we could write all of them that we wanted, and it wouldn't guide the behavior of a complex adaptive system. So we have to think about governance here, about giving direction without giving directives. You see, there's a paradox there. We want to set direction, but we can't force people, we can't direct them. Maintaining authority without having control. So we have to get comfortable with that idea that we've got seemingly opposed ideas and concepts here and find a middle ground forward. Complex adaptive systems are nonlinear. Small changes can have really big impact on the entire system. So that constant evolution is unpredictable. A direct, for example, with a nonlinear change in our system that I suspect is going to have enormous ramifications. It has already here in Rhode Island for us. I mean, it changed so many things in our path forward in health information exchange and achieving the kinds of outcomes we want to from our digital infrastructure. It was one of those small changes with just enormous impact. Simple rules guide complex behaviors. Keep that in mind, because that's the hallmark of what governance has to look like for a complex adaptive system, is the idea. You remember when scientists wanted to mimic the flocking of birds on a computer, and they originally wrote very complex algorithms thinking if they just detailed it with enough code, they would be able to mimic that. They were unable to do it. It was only when they wrote in simple rules. They called these computer bird boys that, for example, fly as fast as the rest of the flock. When you're tired, fall to the back. Stay toward the center of the flock. Only when they wrote simple rules were they able to mimic that complex flocking behavior of birds. So it's important for governance. And hierarchical top-down approaches are ineffective. It's attractors and simple rules that are the key. So with that context, next slide, please. The governance here, again, we're realizing that we've got these things that are diametrically opposed, or they seemingly are diametrically opposed. So it will be a challenge for governance going forward. But next slide, please. As we thought about the takeaways from this digital infrastructure workshop, specifically referencing the governance component of this, our thoughts were around the takeaways is that the decentralized governance model is the one. It's adaptive and flexible to the evolution. We couldn't have a big centralized, heavy-duty controlling governance model. It's got to set parsimonious standards that allow for basic information sharing, leaving all other responsibilities and authorities to local organizations. Building trust by disseminating momentum, and this is raising the visibility of the value of the system to people so that they see a greater and greater value in use of the system, understanding its utility to the public. And we wanted to respect the values that these are the ones that we know, those that are held paramount are going to determine the governance structure and actions that evolve. And you see them listed there, the societal values that we have, good governance standards, the health sector ideals that we want, technology concepts of innovation and flexibility, and certainly economic ideas where this is just to promote value and to prevent waste. So I'll conclude here with a couple of slides on just some areas where we, next slide please, looked into. We looked at strategy options in these 6 areas. Next slide. Under vision, we looked at examples of strategy components that would have to be put forth by this governance group, would be setting up some expectations for the purpose of this system. Certainly putting together the guiding principles. Those are the simple rules we talked about. A modus operandi, how does this thing operate, and keeping that global perspective. So those are the strategy components that would have to be built upon and explored and built out in order for us to achieve the vision components of this next slide. The guiding principles, these were again the simple rules. We had to explore the most decentralized level to which standards could be delegated. Designing the approach to be adaptive to change, looking at standards that are just regarding the major functional requirements, no more, no less, and balancing public progress and individual prerogatives. Next slide. Participants, this was of deep importance to us, as I mentioned before, identifying some stakeholder roles and responsibilities in establishing and implementing this governance system, because somebody has to start somewhere with it, and there's got to be some. And of course, that's the conundrum, that's the challenge. The Internet doesn't have there's no ruler of the Internet. There is, however, the group that determines these protocols, the Internet Corporation for Assigned Names and Numbers, ICANN, a group out of Marina del Rey, California, that governs all the technology and policy aspects of the underlying core infrastructure, but they're not the boss of the Internet. So it's a really delicate balance here about these, but that system of governance was put into place, and we'll have to too. Next slide. The establishment of it, to propose and steward a process. So one of our recommendations out of this was to initiate a round of collaborative discussions among some national counterparts, perhaps people that were part of this IOM work and others. Establishing a representative working group for some initial input, and then certainly factor in an approach to the international community. Next slide. Protocol stewardship. This is very much some monitoring and maintenance of grid protocols for query, discovery, security, and so forth. Approaches to managing variability across participants, and then incentives for stakeholder conformity to the goals and principles. Again, incentives because it's a complex adaptive system, and there's a lot of independent actors out there. Some of that behavior will definitely be governed by standards and the prevailing legal and regulatory framework, but there are other adherence to principles that we're going to need to incent. Next slide, please. The continuous evaluation. This is just getting back to that idea of establishing an approach to ongoing assessment of the problems. Is it how's this thing working for us? Is it achieving the goals and objectives that we were looking for? So thinking too about the how it we're looking at the value benefit realization, promoting successful practices, and certainly supporting research on the orchestration of this ultra large scale system as an e-health utility in both the U.S. and globally. The next slide just shows you the URL for the report. And this is just a wonderful, invigorating, just a terrific opportunity. Oh, I don't see that slide with the URL. It must not have come through. But we'll make that available to you if you're interested in downloading the entire report of our work last year. And I'll end there. Thank you.
Thank you, Laura. That was really, that was fantastic. And it seems, like very impressive work that came out of this series of workshops and the continued thinking. So thank you. We do have probably about 15 minutes for questions. We have a number of questions rolling, so I'm just going to jump right in. First, I think this one is for you, Laura, around governance. How are patients or consumers, the voice of the patients or consumers, expected to be involved in governance model?
The discussions about that were ongoing, and they were constantly a part of the conversation. We had some tremendous representatives of consumers and consumers themselves there at these meetings, and there was the sense that if there is, for example, like ICON, a governing board, they are on that governing board, that they participate in every one of these developmental discussions, that there is attention paid to patient voices in all of this, in the sense that beginning to recognize and understand what it means that we're only about 10 to 12% of the effect on health and expected lifespan and mortality in this nation. And so to do what we did with that particular, now we were called on it in May when we did our press conference on the official release of the report. There were other consumers in the audience that had even better ideas for how they might be more engaged in the future going forward with the planning of this. There were times when people said, why don't they comprise the entire governing board? So I think there's some really creative ideas about that. I think that's an idea we ought to explore. But those are the things that we talked about, looking at how do you turn this thing completely on its ear so that we aren't following the same old path of come and get it healthcare, or we define healthcare by defining it through the lens of the healthcare system. And so we talked about some pretty radical ideas, like the governing board being now certainly no decisions, or maybe we weren't in the position to decide anything there. This was a group getting together with a lot of interest to make some recommendations.
Thank you, Laura. How about, I think this one maybe is for Joy, or possibly Chuck could comment as well. But given all the complexities around the use of information and how, some things require patient consent and others don't, are there efforts underway to do public education to help raise awareness among the people about the importance of having their information shared and the value of that in terms of just for quality and care coordination, as well as for public health and research purposes? So what education programs might be coming or underway?
So this is Joy. Can you hear me?
Yes.
Okay. There are efforts at ONC there is a consumer program, education and outreach program now at ONC to help educate individuals about the benefits of EHRs and sharing their health information. And it has just recently been initiated. That effort is being led by Regia Riccardi, who some of you may know, who has worked with the Merkel Foundation in the past and has also been very active working with the National Partnerships Consumer Coalition that they run. So yes, there are efforts being made there, and there are also efforts being made at OCR to educate individuals about their privacy rights and how the information is shared as directed by the HITECH Act.
Thanks, Joy. Chuck, did you want to add anything or no?
No, Joy really summarized the efforts that are in place. I would only want to put in a plug for education here. I think Joy's presentation, which was excellent, really pointed not only to the applicable rules and regulations and laws that are in place, but also to the complexity of those. And I think it really falls to all of us as professionals in this field and as educators to find ways to help the public understand all of this and what it means for them. So these programs that are being put in place are extremely important, and I think they will benefit the development of the learning health system.
You know, I'd like to comment a little bit more on what Chuck just said, which is it is complicated, and it looks very complicated when you see the summary the way I gave it, even though I tried to simplify it. I think it is a little simpler if you are an entity that is participating in some of these efforts, because you know where you stand. So you know who you are. You should be able to identify who you're sharing the information with and what the purposes are. It gets, at least for now. Now, when you're talking about a learning health system and all these potential sharing some of this information with a lot of entities who you may not really know directly, I think that's going to add a whole other level of complexity on it.
Very good. Thank you, Joy and Chuck. So on a sort of related note to the patient engagement, we have a question on how does the personal health record, either formally or informally maintained by the patient, fit into this new learning health system in terms of how it may be used by providers and how a person gets their information into the PHR and then into the system. I don't know, Chuck, do you want to take that one?
Sure. It's a great question, and I'll be interested in what my colleagues, particularly Laura, think. There clearly is a role for patients' personally controlled information that might be stored in a personal health record as part of a learning health system. I think participation in and benefit from the existence of this system for individuals will be critical to building trust in it and the ultimate success in it. So I think I'm making a statement of principle and aspiration more than giving a technical answer. I think the solution that will be the working learning health system will have to find a way to build personally controlled health records and personal health record systems into its operation. Laura, you want to elaborate on that a little bit or disagree with me perhaps?
No, I agree completely, and I think there are a couple of exciting developments that I'm seeing. As part of our Beacon work here, the Mayo Beacon is doing a terrific job with patient-reported data, and what we're really learning as a Beacon community out of that is that, boy, if we want patient engagement, the idea that they're going to be submitting their own data about things that they care a whole lot more about than some of the metrics that we're collecting. As I try to engage my community here, the idea that they would be able to submit their own information into the system. And, of course, as we dig deeper into this, we realize things like, yeah, that's what their medication history says, but they stopped taking that drug and they only take half of that pill, and the doctor told them to cut this dose down or double that dose. We realize that current meds are way different than medication histories and medication lists. So the idea that the patient needs to supply real-time information into the system, the awareness of that is growing by leaps and bounds, and the value of that. So we're exploring something like, for example, with our health information exchange here in Rhode Island, how would we be able to put a personal health record front end on that to manage sort of the retail acquisition and uploading of data, bidirectional flow of data in and out of our EHR that comes from the patient and family. So I think we're getting a really strong realization of the value of that to achieve all these objectives that we're all interested in, and certainly that it could be a very strong key to patient engagement. So we're working hard on how do we begin. The PHRs are, the industry is nascent, very nascent. So in terms of standards of information that might come out of a PHR, of course it's not there. With Direct, we can do an awful lot of uploading of types of documents out of there into our EHR because we made our HIE, because we made our HIE one of the connection points that Direct sends to in Rhode Island. So patients would be able to do that, but it isn't exactly how we're going to get it into their longitudinal record. We have some challenges around that. So there's a lot to be thought through around it, but the motivation's high.
So another one coming in here. So how does the Learning Health System align with the patient-centered medical home model? Laura, do you want to start on that one?
I think it has tremendous alignment because the thing that patient-centered medical home is doing for us here is it's certainly building a much, much stronger business case for the exchange of information. The idea that we can't really develop functioning patient-centered medical homes unless specialists are able to communicate, unless we're able to look at longitudinal records, unless we have good patient-reported data that the case managers can go in, unless we can look at the population health and look for those hot spotters and so forth. We're realizing just how much dependency we have on this digital infrastructure. So first of all, it provides great clarity on now what is an emerging business proposition for this, which is something we've lacked for so long. And then, of course, we begin to see the input of information out of that clinical setting into research settings, the likes of which we've never had before. We just haven't had access to patient information coming out of the ambulatory world in the way that we needed to come, fluidly, real-time, in large quantities of vast scope. So I can see that as sort of nodes on the system, if you will, the ability for us to extract the information, the ability for those patient-centered medical homes then to use the results of what we're going to be much more rapidly learning out of this system. Science will come to them faster in a more usable format. I think they'll participate in research in ways that they've always wanted to, but it was too burdensome to do because of the ultra-large scale systems that will allow a freer flow of data. So I think it's marriage made in heaven. I think that they will reinforce each other.
Wonderful. I also want to say, Laura, we realized we missed your last slide, but we have posted for the audience your link. So we are making that available. Sorry about that. I think we have time for maybe one or two more. So this is an interesting one. The question is, would the Learning Health System entail nationwide collaboration among organizations sharing experiences that they've learned from implementing EHR systems and working toward achieving meaningful use? So do we see that as a part of the Learning Health System?
Well,
I guess I'll ask you, Chuck. Sorry, I didn't direct it to anyone.
This is Chuck, and I want to answer the question at two levels. At the literal level, which is one way of interpreting the question, I would say that ONC and its partners have other mechanisms in place, like the learning communities being organized through the HITRIC as a way for individual practitioners and hospitals and other organizations to share their experiences and best practices reaching meaningful use. So that's at the literal level. I think the answer is that there are mechanisms for that in place, but they are only tangentially related to the learning health system. But at a sort of spiritual level, I think the two concepts are very closely related because both really relate to continuous improvement. I think the learning health system is all about collecting information from multiple stakeholders, reflecting their unique perspectives, putting that information together to derive new knowledge and feed it back so that whatever those entities are trying to achieve is done in a more efficient and effective way. And I think the spirit of that question, how can stakeholders work together to share their experiences around the attainment of meaningful use, and what the learning health system is trying to accomplish through the way it operates are very harmonious.
Any other comments on that one, Laura or Joy?
No.
Okay. I think at this point we do need to bring it to a close. I do want to mention we have a few questions in the queue that we didn't have time to get to, so we will work offline with our speakers to get those questions answered and get those posted. Thank you so much, Chuck, Joy, and Laura. This was a really very, very interesting program, and I think we went, deep into both the policy and privacy and governance concepts around the learning health system. So thank you, and thank you to our audience for being with us today and for all of your great, thoughtful questions. Before signing off, please do just take a moment and fill out the survey on the right-hand side of your screen. Your feedback is very, very important to us, and we do, in fact, use it to shape programs going forward. So, again, thank you, everyone. If you need more information about Nihik University, please go to our website, and we hope to have you join us for some of our upcoming programs, including this Thursday, our continuation of the Spotlight series on accountable care. So with that, I thank you, and this concludes our program. Have a wonderful day.
Thank you.
Thank you.